for me as president of the ISBD to serve here as a speaker in this webinar for the International Bipolar Foundation. We are looking forward to more collaborations in the future, but I think what I noticed already is that many members of the ISBD are also active in the foundation, which I think is very good, and I look forward to meet the officers of the Bipolar Foundation also in our upcoming conference in Miami in June later this year. When I was asked to present a webinar, I was thinking of what topic I would choose, and I think it might be a good idea to speak for you about lithium, an old drug for the treatment of bipolar disorder. I think actually the first drug that was developed, and still one of the first choices, especially for the long-term treatment. I know that it is not that popular in the United States. It's much more popular for instance, in many European countries. I do not know exactly why, but maybe one of the reasons is that it was not invented in the US actually, but it was invented to some extent by an Australian, but later on it was further developed in Europe. And also it has its complications. It's sometimes a difficult drug to be given, especially when you're not a specialist. This is the drug. It's a simple molecule, and here you see how it is harvested actually in South America. This is in Peru, where you see how it is taken from the ground, and it is drying here. And from this mineral, it is made not only for our treatment, but also, as we know very well, for our batteries. It was not discovered by the pharmaceutical industry, but actually discovered by clinicians, and not clinicians, but clinicians. And in the middle, you see John Cade, an Australian, who was one of the first to describe its effects in the 40s of the 20th century. And you see on the right Mogens Schou, who further developed it later on. This is one of his first interesting papers published in the 50s, 1954, in which he demonstrated in a series of patients how this drug indeed seems to diminish the number of manic and depressive episodes when given to his patients. And you see here in black when the drug was started in the first patient in 54, and then you see how episodes disappeared, came back when the patient stopped his lithium, and then returned again. And you have more examples of that. It was not enough to convince the authorities to register lithium. That took another more than almost 20 years, but in the 70s it was registered. I started my psychiatric training also in the 70s, and when I was a resident and also a young psychiatrist, I started to use lithium, but also found out that it did not work in every patient. So already in the 80s, we also started looking for alternatives. And one of the alternatives is the anti-epileptic drug carbamazepine. And I know very well Bob Post from that time working at the NIMH, that he started doing studies with carbamazepine as an alternative drug or as an adjunctive drug to lithium for his patients. And here you see a paper by myself, also published in the 80s, in which, in the same manner, you see here on the bottom the dashed line where a patient started with carbamazepine in addition to the use of lithium at the end of 1980, and then the patient recovered. That brought us already in the 80s to the question, would there be a preference for patients to use lithium or other drugs? But before starting to discuss the efficacy of lithium and also to discuss the efficacy of other drugs or different comparisons that have been made, I would like to discuss a more methodological point with you, how to start long-term treatment. And sometimes long-term treatment is considered continuation treatment, a treatment that you start during an acute episode, and if the patient responds, then you can continue the same drug to prevent relapse and ultimately also to prevent recurrence, so the return of the illness after 1 or more years. But you also can use the drug more or less as a pure prophylactic treatment. You can use antipsychotics or sometimes called neuroleptics to treat manic episodes. You can use antidepressants that might be effective to treat the depressive episodes in patients with bipolar disorder. But in addition to that, if you have achieved that the patient is in remission, so you have treated effectively his manic or his depressive episode, then you also might consider to use another drug to prevent further episodes. So that is one of the reasons why antidepressants has not been that popular. You can use them to treat an depressive episodes, but you can end up in a manic episode when the patient switches from a depression to a manic episode. And you also might have that with some of the especially older neuroleptics. Here you have it more in a graphic. You see here in red a drug that is started during the acute episode, and then so in red the manic episode, and then when the patient recovers from his manic episode, then you can continue the treatment initially to prevent relapses and later on also to prevent recurrences. So you're using the same drug for continuation treatment that you were also using for the acute episode. That is not the case when you use a drug purely as a prophylactic agent. Of course, you can use lithium in manic and depressive episodes, but especially when I was trained in psychiatry in the 70s, we learned to use lithium as a prophylactic drug, so in addition to antidepressants and to antipsychotics. Let's go. In about, well, 8 years, no, 8 years ago, John Gaddis from Oxford made a publication in which he discussed the available evidence at that time on the use of lithium in comparison with placebo in the long-term treatment of patients with bipolar disorder. And that was done in the so-called Cochrane meta-analysis published in the American Journal of Psychiatry. He looked in the whole world literature for randomized controlled trials in which lithium was compared to placebo. In some of these patients, lithium was already used before, so it was allowed that patients had used lithium also in acute episodes. And what is very important in these studies, that he also looked that when patients were switched from lithium to placebo in this design of these studies, then the drug should not be stopped abruptly, but should be stopped gradually in order to avoid a discontinuation syndrome, or in order to avoid the early development of a relapse. When he looked for this criteria, he ended up with 300 papers that might be interesting to him, but finally they could include only 5 studies. So the whole world literature up to 2003 consisted of 5 randomized controlled trials in which lithium was compared with placebo. 2 studies that were done in the 1970s that led to the registration of lithium. Then 20 years nothing happened, and then after 2000 another 3 studies appeared. And these are the 5 studies. Yeah. Here you see the study by Pryan and a study by Kane, 2 US studies. And you see the first one with 100 patients receiving lithium and 104 patients receiving placebo. All patients had been used previously. I will show you how the study was designed later on. But what is important in this slide is that you see that there was a difference whether or not patients were using lithium before. So in most of these studies, actually the use of lithium had started in an acute episode, was continued to after to prevent relapse, so the early return of symptoms, and then it was continued later on to prevent recurrences. When John Geddes and his colleagues further analyzed the data from these studies, they could prove that lithium prevented episodes. And here you see how they were doing that. You see here a line from above to below at 1.0. And when all the studies are shifted to the left, it indicates that on the left side, the active drug, in this case lithium, was more effective overall than placebo was. We also looked more specifically for manic episodes and for depressive episodes, and then they could prove that lithium indeed also prevented specific manic episodes, but they could not prove at that time that lithium could also prevent depressive episodes or depressive recurrences. So the conclusion from this paper, based on the whole world literature until 2003, was that actually in the long-term treatment there was a proof that lithium could prevent episodes of bipolar disorder, especially manic episodes, but there was no proof that it could prevent depressive episodes. And so more or less the awareness was there that lithium was not that effective in the prevention of depressions. This is the original study that was done by Brian et al. You see that initially patients were randomized for a manic episode, were treated with lithium, always the classic antipsychotic chlorpromazine, the first antipsychotic that was available in the market and was registered in the 50s. When patients had recovered from the manic episodes, then all these patients were treated with lithium and were further stabilized. And then at a specific moment, patients were randomized either to continue lithium or to gradually stop and finally end up with treatment with placebo. And you see here what happened. The relapse rate over 2 years was over 40% in the patients who continued lithium. So 60% of them remained well. And you see what happened with placebo. The relapse rate and the recurrence rate was over 80%, so only 20% of them remained well. So you see here there is a strong evidence from this study that lithium is an effective treatment. And this finally led also to the registration, this study specifically led to the registration of lithium in the United States. This is one of the studies that was done in the year 2000. In this study, 3 treatments were compared, Valproate, placebo, and lithium. It was the registration study for Valproate that was done in the 90s, and finally was published by Charlie Bowden from Texas. And actually what happened in this study is that patients were initially treated with whatever drug for a manic episode. That could be lithium, that could be Valproate, but it could also be other psychotropic drugs. They were tapered off when the patient had recovered from his manic episodes, and then when they were on lithium or Valproate, that could be continued. And you see here that at a specific moment patients were randomized. So when they were using an active drug, it was stopped, but they could also be switched to Valproate or to placebo. And this was the outcome of the study. And you see here on the in the middle whether or not manic episodes did appear, and there was no difference between Valproate, placebo, and lithium. Besides, on the right, you see also depression, and in that case, there was a difference between the yellow bar for Valproate and placebo, and Lithium more or less in between, that Valproate did better prevent depressive episodes, and that ended up on the left, that also when you take everything together, there was a difference with regard to any mood episode. So there was an indication from the study, although it was not the primary goal of the study to look for depression, that was mania, but there was an indication from this study that Valproate did prevent depressive episodes, while it was uncertain about the efficacy of lithium. So it was more or less a negative study, especially for lithium. Then there were two other American studies, also two other studies also done by an American colleague, Joseph Calabrese from Cleveland, Ohio. And in this study, patients were initially treated with Lamotrigine for a manic episode or for a depressive episode. When patients received Lamotrigine, it could be added to other psychotropics. When patients recovered, then the other psychotropics were tapered off. And when then patients remained stable for another 2 weeks on monotherapy with Lamotrigine, then patients were randomized either to continue Lamotrigine on the top, to switch to placebo, or to switch to lithium. And this was the outcome of the first study in patients who were initially treated with Lamotrigine for mania. And you see here that lithium and Lamotrigine prevented the recurrence of mood episodes. Only about over 2 years, about 1.5 years, about 50% of the patients relapsed. It's still a remarkable high relapse rate, but the relapse was around 80% of the patients who were switched to placebo. And there was no difference here between Lamotrigine and lithium. But very interesting, the yellow line on the left in the prevention of manic episode was better for lithium, and in purple on the right slide, you see here that the effect of Lamotrigine was better in the prevention of depressions. Similar thing happened in the other studies they did in patients who had been given this drug for an acute depressive episode. The difference were not that big overall, but here you see the same indication, lithium on the left, better prevention of manic episodes, and Lamotrigine as a better preventive drug for depressive episodes. So that was more or less the basis for that meta-analysis by John Caddis from Oxford, which I presented you before, that from all these studies available in the early 2000s, then it came out that lithium was a preventive drug for the prevention of, was an effective drug for the prevention of manic episodes, but no good proof for the prevention of depressive episodes. I already mentioned you that I studied carbamazepine as an alternative for lithium in the 1980s, and at that time we thought we might have two active drugs, lithium and carbamazepine, and we were thinking of whether or not there would be a reason to prefer lithium over carbamazepine or vice versa. So what drug would you start? Or would there be a specific patient that would have a preference for lithium or for carbamazepine based on whether or not there might be a difference efficacy? So what of these two drugs would be the good first choice? This is a very complicated slide, but I think what is very important here is that we designed a study in which we included patients that could be manic or depressed, could be treated with other drugs, but all these patients never had received carbamazepine of lithium before, so they were naive for the treatment with these drugs, and we randomized them either during an acute episode or thereafter when they had recovered, but actually we then stopped the other psychotropics and we continued with only carbamazepine or with only lithium for another 2 years. That was a study that was done in the Netherlands by Erwin Hartong. And I was the supervisor of that study at that time. And here you see the outcome. In patients never been treated before with lithium and never been treated before with carbamazepine, indeed we found that lithium was a more effective drug than carbamazepine was. So at that time we decided, with the at that time available drugs, that lithium was a good first choice for the treatment, for the long-term treatment of bipolar disorder, and we only used at that time carbamazepine as an alternative in patients who failed on lithium or did not tolerate lithium or what might happen. And we could add carbamazepine or we could switch to carbamazepine. Then in the late 1990s and the early 2000 years, then the first atypical antipsychotic became available. And as you know, many of them have been registered these days for the prevention of manic episodes, and some of them, especially Quetiapine, also for the prevention of depressive episodes. And it has been very successful drugs in terms of market sales, etc., for the long-term treatment of bipolar disorder. But unfortunately, only 2 of them have been compared directly with lithium. And this is the first drug and the single study that was done comparing lithium with Olanzapine. That was a study done by Mauricio Toen, my predecessor as president of the ISBD. At that time he was working for Lilly company. Nowadays he's back in academia, and he's working together with, he's working in Texas together with Charlie Bowden. In this study, patients could be treated with other psychotropics, but then in these patients, Olanzapine was given in combination with lithium to treat a manic or a mixed episode. And when patients recovered from the episode, then they were randomized to continue with only Olanzapine or with only lithium, monotherapy Olanzapine or monotherapy of lithium. They excluded patients with a poor history of lithium, but actually many of these patients had already been given and been treated with lithium before. And as Olanzapine was a rather new drug at that time, this study was actually done in the 1980s. It was published in 2005. So there might be a selection of initially poor responders or patients not doing very well on lithium when they participated in this study. This was the outcome of the study. No significant difference, although there is some indication that Olanzapine might be somewhat better than lithium, but it was not statistically significant. There was a statistically significant advantage of Olanzapine in the prevention of manic episodes, while drugs were apparently similar in the prevention of depressions. So it more or less it is unresolved whether or not there would be a preference for lithium or for Olanzapine based from this single study. And what we know nowadays is that many patients receive atypical antipsychotics such as Olanzapine for the long-term treatment, and lithium has become rather unpopular. So that was more or less the situation until rather recently. I think 3 important new studies became available, and I was involved in one of them, and I think it might be interesting for you to hear more from these 3 more or less recent studies. The first one is a study that was done by AstraZeneca in the process of the registration of their compound, not only for the treatment of acute manic and of acute depressive episodes. The compound is Quetiapine or Seroquel, but also it was further developed as a drug for the long-term treatment of bipolar disorder, so in order to prevent relapses and recurrences. And it was the design of that study. More or less similar as the Lamotrigine studies I showed you before. Patients over 2,000, almost 2,000, actually 2,300 patients were selected for this study. It was a study done in many countries all over the world. They could receive other psychotropics, but at a certain time, Quetiapine was started as the treatment. Patients were tapered off from the other drugs, so it was monotherapy, 300 to 80 milligrams, and those patients who did well, tolerated the drug, and remained stable for at least 4 weeks were then asked to participate in a randomized control trial in which they could be randomized to 3 treatment arms: Quetiapine, 300 to 800 milligrams, so the continuation of the initial successful drug, or the switch to placebo, or the switch to lithium. So this was the design of the study, and then patients were followed up to 2 years to see whether or not they got a recurrence. And this is the outcome of the study. A very strong effect for Quetiapine, but also a very, in purple, but also a very strong for lithium in white compared to placebo in blue. You see a small advantage of Quetiapine, especially during the first year over lithium. So there is an indication that Quetiapine might be better for these patients, but you have to realize that at the time of randomization, and that was shown before, I will show you here again, all the patients were already using lithium. So we know of all these patients at the time of randomization that they were probably doing well on Quetiapine, so there might be a selection, and it was actually 1,200 patients that were randomized based on the more than 2,000 patients that were selected from this study. So the other half of the patients did not reach the time of randomization. But what's very interesting from this study is that for the first time it was not only shown that Quetiapine as well as lithium did prevent manic episodes on the left, but also there was a very strong effect in the prevention of depressive events or depressive episodes on the right. So that was the first and also the largest study done with lithium that showed in this case that lithium not only prevents manic episodes, it was already found in that meta-analysis I showed you before, done by what's his name, John Geddes, but we also now could prove that this drug was very effective in the prevention of depressive episodes. There was also a big problem with the study, which made this study, I think, very interesting for clinicians, and I hope also for patients to better understand how to use lithium. And that's why I had these 3 last words in the title of my presentation, that lithium is effective when used properly. Many patients receiving lithium, and that were about 400 patients, actually many of them did not receive enough lithium, resulting in a plasma level which was below 0.6 mEql per liter, so a too low plasma level. The aim of the study was to treat patients with lithium at a plasma level between 0.6 and 1.2, but actually only 200 patients achieved that plasma level, while almost 150 patients never achieved a plasma level above 0.6. So they remained throughout the study below 0.6. That was a failure of the organization of that study. So something went wrong. What exactly is unknown, but the manufacturer AstraZeneca was, I think, not very happy with this outcome of the study. There was a problem how to deal with the interpretation, etc., etc. Fortunately for them, they could prove that Quetiapine was better than placebo in the prevention of manic and of depressive episodes. So their registration was given for that indication. But with regard to lithium, it provided, it created an opportunity, what we call a disadvantage, but also every disadvantage has its advantage. And that led to another publication published a few weeks ago on the issue, on the comparison, where is it? On the comparison of patients these two groups of patients receiving lithium. And here you see that actually we could compare three groups. Lithium, 137 patients, lithium below 0.6, and you see that the composition of the patients group is not similar. So actually this was not a randomized study, but it is how it happened in this study. While, for instance, you look for rapid cycling course, while only 11% of the patients receiving placebo and also 11% of the patients receiving lithium at an adequate level between 0.6 and 1.2, almost twice as much patients, 18% of the patients who receive lithium below 0.6 were rapid cyclists. So it might explain, you never know, but it might explain some of the difference in the outcome. We checked for it in our analysis, and we could not found that these different distributions affected our outcome, but you have to realize that it is a kind of indirect proof. But what we found is very interesting. And here you see the major finding on the primary outcome. You see here in light blue a huge difference between placebo in lithium in light blue and placebo in red. And you also see here that in dark blue, lithium below 0.6 did not separate from placebo. So to achieve an effect of lithium, you really need plasma levels above 0.6. And I know in clinical practice, I know it also from big studies that were done in the US, such as the STEPID study, that actually many patients in the US receiving lithium are not checked well enough for the lithium plasma levels or are treated with lithium plasma levels below 0.6. And I think that to achieve a therapeutic effect of this drug, we now have this proof available from this large study that in order to achieve an effect of lithium, really we need these plasma levels above 0.6. I go further and I can show you here that that is the case to prevent manic events and also to prevent depressive events or depressive episodes. So what we know from this study, I think two important things. First, this study for the first time proved that lithium is effective in the prevention of depressive episodes, and for that effect we need a high enough plasma level. Then I would like to end with two other recent studies. I think this is also a very important study that was published 2.5 years ago in the Lancet by a British group of investigators, including John Geddes again, in which he compared in clinical practice lithium and valproate. This was the design of the study. Initially, patients were receiving lithium and valproate together, and then they were randomized when they stayed well and were stable to monotherapy with lithium at, for some patients, rather low plasma levels, 0.4 to 1.0. So with the recent study taken into account, I think they should have chosen at least 0.6. The combination treatment and valproate as monotherapy, also based on plasma levels of at least 50 milligram per liter. This is the outcome of the study. In blue, the combination, so that was the most effective treatment. In black, monotherapy with valproate, and you see here that around 70–75% of the patients relapsed on monotherapy, while that was only for 55% on the combination. And in between, lithium, which was significantly different from valproate monotherapy, but was not significantly different from the combination therapy. And especially when you then also realize that probably quite a number of patients probably received too low lithium plasma levels, then I think this study clearly indicates that lithium is to be preferred as monotherapy over valproate as monotherapy, while you also can give combination therapy. And in clinical practice, I think we often still start with lithium monotherapy and then add other drugs like Valproate in patients who are not doing well on lithium. This is manic episodes and for depressive episodes. And here you see for depressive episodes that lithium was absolutely similar in the prevention of depressions as the combination, and both separated from Valproate. And finally, also a very interesting approach that was a Danish study in which also John Geddes and Guy Goodwin participated from the UK, and that was based on the use of these two drugs in clinical practice. In Denmark, they have the opportunity to compare various registers, and actually the Danish Psychiatry Register that has data on all the Danish psychiatric patients with their diagnosis, and the Danish Medicine Register, in which they have on every inhabitant of Denmark the type of medications that they were using. So from the total Danish population of more than 5 million people, all individuals with a first-time diagnosis of bipolar disorder, that were more than 11,000 patients, and subsequently receiving lithium or Valproate, were included in that study, and they excluded patients that had used lithium or Valproate before. And then they looked in these registers whether or not patients were subsequently hospitalized for a depressive or for a manic episode, and whether or not patients were switched or got other medications added in clinical practice as an indication that apparently the patients were not happy or not satisfied with the outcome of lithium or Valproate alone. And here you see what happened when you look for the total group of patients, so not the patients that were initially included with a depression or an index episode of mania or a mixed episode, but when you look for the total group of patients, you see that there was the outcomes favored lithium over Valproate. So on the right, you see favoring of lithium at the bottom of the slide. That when you look at overall hospitalizations for depression, hospitalizations for mania or mixed episodes, and also whether or not patients were switched or got other medications added, lithium did better than Valproate. So based on the clinical practice, you see the curves also favoring lithium over Valproate, both for hospital admissions and switch to other medications. The conclusion of the authors was that treatment with lithium apparently in general and overall was superior to treatment with Valproate. Of course, you have to take into account that it was a completely naturalistic study based on what was happening in Denmark, and it is not unlikely that what we call channeling occurred. What is meant with channeling, that actually the more complicated or more difficult to treat patients finally end up with a prescription of Valproate compared to starting with lithium. So it is not a proof, but it is, I think, very good circumstantial evidence that lithium is a drug that is to be preferred. So my overall conclusions, based on the two recent studies that were done in collaboration with AstraZeneca on their Quetiapine studies, I think we can conclude that lithium is proven effective in the long-term treatment of bipolar disorder. It prevents manic and depressive recurrences, and plasma levels should exceed 0.6 mEql or millimole per liter. It appears to be a better preventive drug than Valproate and also than carbamazepine. There have been no fair comparisons with atypical antipsychotics, which you could discuss maybe a small exception for the single study done with Olanzapine. Of course, we have to realize that lithium is not a drug that is free of adverse effects, and I mentioned here only the four most important of them. Three more kidney problems, thyroid problems, and weight gain, which, however, is not that as a big problem as with some of the atypical antipsychotics. And of course, with lithium, we know there is always a risk of intoxication. It is a drug that needs to be closely monitored with regular blood assessments, etc. With regular blood assessments, etc. So this was my presentation for you, and I would like to thank you for your attention.
Thank you so much. That was wonderful.
I hope it went well.
It was terrific. Thank you. So on your control panel, there is a box where you guys can submit questions, and we will start to answer them. Our first question is, could lithium be less popular in the U.S. because of highly marketed and more profitable alternatives?
I think that is one of the reasons, one of the major reasons. I think U.S. doctors are more susceptible for marketing maybe than in Europe. I think another reason is the fear of intoxications and the fear of legal problems, etc., etc. When you end up with an intoxication, how responsible is the doctor? Though there might be also a fear of suing. And I think in Europe we are more used to use lithium than in the US.
Thank you. The next question is it true that once you start taking lithium and then stop, manic episodes can be worse?
Probably not worse, but when you stop abruptly, then you have the chance that you end up very quickly in a manic or in a depressive episode. So if you are using lithium and you would like to stop it, it's always recommended to taper off slowly, and most of the times we do that over a period of at least once, but preferably over 2 or 3 months. So gradually tapering off. Also with the option that as soon as patients begins to show signs of a recurrence, then you immediately can increase up to the original dose. So the recommendation is when you stop lithium, do it slowly and taper off.
Thank you. This is regarding someone's son who is currently on lithium and a few other drugs. He's very immature and mood changes fast. What else can be done other than raise lithium to stop mood swings?
I think what is very important is to check the lithium plasma levels to see whether they are in the adequate range. And normally we start a lithium plasma level between 0.6 and 0.8, and if that is not effective enough, then we increase the dose to obtain plasma levels around 1.0, so up to 1.0. But what we already knew in the 70s and in the 80s, and what we still know, is that it is not working in every patient. Unfortunately, these days we have many other alternatives, and what you see in clinical practice is that when patients tolerate and at least achieve some effect of lithium, then you can add other drugs like Lamotrigine in patients who have recurrent depressions, or atypical antipsychotics, and one of the most used drugs, and I think in addition to lithium, also the drug with the best evidence for efficacy in both prevention of manic and of depressive episodes is Quetiapine. So you can come up to a combination of lithium and Quetiapine. You also could consider adding anticonvulsants such as Valproate. So you're ending up often in a combination of 2 or even 3 and maybe even more drugs. But the first option, I think, is to go for a monotherapy. And if the patient tolerates lithium, I think it's still a wonderful drug.
Our next question is, can you please discuss what can be done to prevent kidney damage? I have 3 consumers in my support group that are on kidney dialysis due to prior long-term use of lithium.
And what was the adverse effect? Thyroiditis?
Prevent kidney damage, because she knows 3 people who are on kidney dialysis due to prior long-term treatment of lithium.
Yeah, that is a problem. What we need to do is regular kidney checks, and you can do that by checking the blood. We do that at least twice a year, and that is also the recommendation from the ISBD. If you look, they have published a report on the how to handle the adverse events of lithium and how to deal with that. When you do these regular kidney checks, then you can detect in an early stage when the kidney is not working 100% anymore, and you can discuss whether or not to stop lithium and to go for an alternative. So that is the first step. Do regular blood checks in order to prevent severe damage when you would continue with lithium without these checks and without knowing that the patient has kidney problems. When you end up with severe kidney problem, you can go even for hemodialysis, etc., etc. And when we have some patients who indeed end up with severe kidney damage, it can be by lithium, but also by I remember a patient with another kidney disease that needed hemodialysis, and as soon as you have this hemodialysis, you could restart lithium when it was a very effective drug for you. You can give lithium in a single dose after the hemodialysis. Then the lithium stays in the body until the next hemodialysis. Then it is disappeared completely or almost completely. You have to give a single dose and go for the next hemodialysis session.
Great. All the studies seem to measure results over a period of weeks. What about patients whose phases last a year or more?
Can you repeat that, please?
The studies all seem to measure results over a period of weeks. What about patients whose phases last a year or more?
Yes. Well, most of these long-term studies, they last 1.5 years or 2 years or sometimes even longer. And they tend to include patients who has suffered at least 3 or 4 episodes of which at least a recent episode or episodes over the past 1 or 2 years. So they intend to include patients with a big chance to develop a next episode within the study period. So you should not include patients who had 1 or 2 episodes lifetime and maybe the last episode 10 years ago. Then you are very unlikely that you could detect an episode in the next 2 years. So they select most of the times the more severe patients with a higher chance of relapse, and that gives you the power to detect difference between treatments or difference between an active treatment and placebo. It's a good question.
Do you have comparable data for bipolar 2?
The study that we did with AstraZeneca, or the analysis I showed you, are data from bipolar 1 patients. So there are not that many data on bipolar 2, but our impression is that lithium is also effective in patients with bipolar 2 disorder, and we also know that lithium is a very good alternative in patients with unipolar depression. It is one of the proven alternatives for patients not responding to antidepressants, that you can add lithium, and then you have a big chance that you finally respond to the addition of lithium, while you have not responded before to monotherapy with an antidepressant. So lithium augmentation is also a proven effective strategy in refractory unipolar depression. Also another indication that lithium is working against depressions and not only against manic episodes.
Great.
Thank you.
When an effective drug must be stopped due to intolerable side effects, how does lithium's rate of relapse compare to other drugs?
Yeah, that's always the problem. That then when you have an active drug and you stop it, so based on the history of the patients, you can have the impression that in that specific particular patients, lithium is an effective drug and you have to stop it because of adverse events. I think the first step could then be try to lower the dose and lower the plasma level and see whether the adverse events disappear. For instance, when you have a tremor, the problem with tremor is less severe when you are treating patients at lower plasma levels, but sometimes you have to stop, for instance, when you are developing severe kidney problems. You also can develop thyroid problems, but you can add thyroid hormone very, very easily, and so a thyroid problem should never be a reason to stop lithium. But so there are different solutions, and when the drug was effective and you have to stop, I think the best hope is that you can find an alternative for lithium that is as effective as well. But you're never sure, unfortunately.
Thank you. When currently taking lithium, people tend to be much more thirsty and drink lots of water, more than most people know. It then leads to crave salt. Is this normal occurrence when taking lithium?
Yes, thirst and drinking more, so polydipsia and polyuria is one of the adverse events of lithium. I did not mention them all, but so that might be also an indication for kidney problems. There are some solutions for it, so as the use of antidiuretics, but it is one of the problems and one of the adverse events of lithium that have to be taken into account and have to be discussed with the physician.
Thank you. Is alcohol absolutely prohibited with bipolar disorder? How does it mix with lithium?
Normal use of lithium, so social use of alcohol is not a problem in patients receiving lithium. The problem might occur when you are drinking too much. Then you can have problems with your water and salt household, and that might affect your lithium levels. So the recommendation is to avoid too high consumptions, but social use, so let's say up to 2 or 3 glasses, so consumptions per day would not be a problem for taking lithium. Hello.
Hi. Are there important dietary, vitamin, or supplement considerations that people taking lithium should remember?
No, I'm not aware of.
Okay. Next question is, what are the best medication alternatives for bipolar 1 who have stopped lithium after long-term use due to kidney problems?
I think the best proven drug after lithium or together with lithium is Quetiapine. So I think that's a very good alternative. And then you have the other atypical antipsychotics, and also to some extent Valproate. I think that are the, and Lamotrigine when you have also depressive episodes. So I think one of the biggest advantages over the past 10-15 years in the treatment of bipolar disorder is that we have now very good data on many drugs, but we have to realize that we also still have very good data on lithium, and that was the reason that I chose for this topic for this webinar.
Thank you. And we have time for 2 more questions. What is the effect of lithium in those teenagers with severe anger and physical outburst?
I don't know data on that. There is some indication that also in youngsters with bipolar disorder, lithium is effective. It has been studied, for instance, by Bob Findling and Robert Kovacs. But I think it should be reserved for the more pure bipolar disorder, and not for, as always, and not with the more not for the people with the more broader criteria. So with the narrow criteria, and even youngsters and even young children with really bipolar disorder, there's no reason to withhold lithium.
Thank you. And our last question is, can thyroid problems from lithium therapy be reversed when tapering off lithium?
Not always, but it can. But it can be treated very effectively, especially the thyroiditis and the Hashimoto's disease. So your thyroid is not working enough anymore. You can add thyroid hormone. You can supplement the patient, and you can follow the patient when lithium should be stopped for another reason. But a thyroid problem should not be a reason to stop lithium. You can supplement with thyroid hormone very easily.
Thank you. And thank you so much for all your time and answering almost all the questions. So we really appreciate having you today.
Thank you very much, and also all the attendees.
Thank you, everyone, and have a great day.
Yes, bye-bye.
Bye.